Appreciate everyone having us. So today I'll be presenting one of our trauma cases that has a little controversial treatment. We'll kind of go over it. We can advance one slide. Okay, perfect. So this is going to be an 82-year-old female. She had a history of multiple falls and gait deterioration according to her family. She fell at her home several days prior to being brought to our hospital. It was at a peripheral hospital she was initially brought to. She had bilateral distal radius fractures and a cervical spine fracture is what we were told. We were one of the referral centers for the Delaware Valley, so the patient was sent to us about 2 days after the fall. It was a little unclear the timeline of everything. Clinically, she was stable at presentation. She had fours in her bilateral upper extremities as well as lower extremities, positive Hoffman, 9+ beats, clonus bilaterally, and according to the family, unsteady gait. She had decreased rectal tone and did have a Foley in place, unable to assess that. Next series of images will be her CT scan at various levels. We can see as we scroll through here, she obviously has a type 2 odontoid fracture that maybe looks acute versus chronic. The chronicity is a little indeterminate. And then the MRI cuts will be shown here. She has significant compression at C2 with cord change there. So the controversy we're going to talk about in terms of fixation for this patient. The diagnosis, of course, can be an unstable C2 fracture, and she has severe spinal cord compression due to this instability. The thing when we really kind of dive down here and look more closely, this is referencing what I'd consider a classic paper by Dr. Rue, and it is talking about the heights of the C2 to look at in terms of when you can safely place screws. So what they consider a high riding vertebral artery, which has been widely accepted since then, is having a superior pars height of less than 2 millimeters, an isthmus height less than 5 millimeters. And those are both measured on the sagittal view, and then looking at the axial view, looking at the pedicle width, and this is less than 4. So kind of thinking of these and knowing these, we return more closely to the CT. So this is obviously the axial view, left side and right side. So you see the left side, fine pedicle size, right side, pretty narrow. And then on the sagittals, see on the left side of everyone's screen, it's going to be the left C2. You see it's 5.2 and then 4.3 for the isthmus. And then on the right side, seems like okay size, 5.7 and 9.5. So based on that, we determined the patient looked like she had small pedicles with a high riding vertebral artery, and pedicle fixation C2 is a little difficult potentially. So procedure we did, and I'll go through the images here. The patient had a C1, C2 instrumented fusion, closed reduction of the C2 fracture. We did this by just extending the neck back, blocking of the Mayfield, and then we also harvested a posterior iliac crest on the patient's right side. So here's some intraoperative views to show. You can see we have our screws, and the screw fixation C2 is going to be what the interesting part is. And you can see immediately here that those are obviously not pedicle screws. They're going to be translaminar screws. I'm going to go through here and post-op. So again, interesting construct. We don't see it too often. They have post-op day zeros up top and a 2-month post-op with a little bit of parallax, of course, proven that from the post-op day 0 ones. Her last note, which I wrote a couple weeks ago, she seems like she's doing well. She's walking with a walker now, but regained, looks like most of her strength, and she's doing well overall. So kind of the debate here is kind of how often you're looking for the high riding vertebral artery in these upper cervical spine traumas and additional fixation methods. And I think Dan Rue's paper is even saying that even if these are high riding, that they still recommend you can get a pedicle screw in there safely most of the time.
Chat, that was great. So let me make 2 comments. One is that there was a classic paper published 12 years ago in Journal of Neurosurgery of Spine that said if you were blind and you were drilling a C2 isthmus screw and you were aiming for the vertebral body, a 14 millimeter in-length screw rarely ever made contact with the foramen. So you're not putting a long C2 pedicle screw in, you're not putting a medialized implant in, so you get a firm fixation. Second thing, the biomechanical studies, and I think 𝐂𝐤𝐬𝐬𝐿 was the first author, showed C2 lamina screws are just as effective as C2 pedicle screws, which I don't believe. So let me ask Rick Sasso. Again, I'm sorry to wake you up, Rick. But in this situation, do you think this patient benefits from a C1, C2, or would you have exploited the occiput? I know it's so morbid, and get better fixation, or do you think this patient's going to fail? You saw the amount of translation. Do you think C2 translaminar screws and that C is stable for this patient?
That was perfect. That was beautifully done. It really was. I would have done exactly the same thing.
Great.
Traction, make sure you can reduce it. Don't even worry about the vertebral artery. The laminar screws are very strong. They are not as strong as the pedicle screws, but statistically, they are comparable. They are.
Great. So let me ask Jens Chapman. Jens, are you there?
Certainly am.
Jens?
Can you hear me?
Yeah, I can see. You got to
Yes.
take off mute, Jens.
I'm with
Okay.
you.
His hand is
I can
raised.
hear you now. So what's your opinion? Would you have done this? Would you have done it any differently? They didn't use They didn't use traction. They used intraoperative manipulation of the Mayfield to reduce that. Would you have felt, because the osteoporosity noted, would you agree with that approach, or would you have done something differently?
I hate to agree, but I am in full agreement with what was done. It's beautifully done, and I think the preoperative planning with a CT is important. I saw in the chat room that people said, oh, go to the occiput, and especially in older people, the C1 lateral mass fixation has been a revolutionary procedure in most patients. Again, the study of the CT is important to make sure there's no erosive disease, that there's sufficient lateral mass there. But for older people to be able to look down so they have ground clearance is a huge deal. And depriving of that by locking them into a occipital-cervical fusion, as nicely as you think you're changing, you're positioning your angle and everything, it's very morbid for older people. So beautifully done, great case. And again, we have done exactly the same thing as Rick has also said, closed reduction, underfloor with neuromonitoring. Be aware of the high riding or medialized vertebral artery. Translaminar fixation is very good. C1 fixation is very powerful with bicortical screws, and go from there.
Okay, so let's talk about graft choices. As grandmother gets into her 80s, mid-80s, are we harvesting the iliac crest? We know the stem cells content is poor. What would you use, Jens, in that situation?
The one controversy, and I typed that in this case, would have been, I would have thought about doing a C1 laminectomy on this patient to make sure that the cord has maximum decompression space. And I usually in these patients do a careful decortication of the C1, C2 joints and insert either half of the spinous process or the spinous process wings if they're large enough, or I use a small allograft spacer. They make them like in 3 to 4 millimeter sizes and gently tap it into the joint under C-arm guidance. So I like to have a C1, C2 facet arthrodesis to restore normal C1, C2 height. Thank you.
And you're not using iliac crest bone graft anymore?
No, I mean, literally not. And I think you raised the
Gotcha.
great point that, especially in older patients, not only do you have the donor side morbidity, but if you veer off the wrong side, you can get stress fractures. I actually had a stress fracture of the pelvis not so long ago from an outside hospital where an iliac crest graft was harvested. So really staying away from the iliac crest, and especially older patients, is a big deal. And you mentioned the lack of osteogenic potential in that vacuous fatty bone.
Actually, there's one question in the chat room that doesn't apply specifically to this case, and it doesn't apply to any cases. So I want to ask Pat Johnson, anterior Joe procedure. Have you ever done it? Would you do it? Resect anteriorly the uncovertebral joint, lateralize the vertebral artery, do a discectomy, no fusion. Did you ever do that?
Yes, I have. And I actually wrote a paper about it with quite a number of cases that we did. And, you know, they probably had about a 10, if I'm recalling correctly, and I wrote this paper, I'm going to guess more than 20 years ago. And it worked well in about 90% of patients, but there was a good 10% reoperation rate.
And you thought you had better outcomes by doing either a formal fusion or another strategy?
Well, I think those patients, I probably today, I still do a lot of posterior foraminal work. If somebody's got a soft disc herniation, I'll take them out from behind. We do artificial discs. I mean, I'm a non-fusion surgeon whenever I can. And, you know, it's changed over the years. But when I did the 𝐒𝐻 procedure and published that paper, I mean, I had a lot of patients that it was just spectacular. You go out and you retract the collie muscle a little bit, you drill down the 𝐂𝐻𝐻𝐵vertebral joints. And I still do that on occasion when somebody has had a procedure that leaves them with a big osteophyte that's giving them symptoms. I will still go drill them down. I use navigation for all that kind of stuff. I mean, it's, you know, we do navigated small decompression procedures. So, you know, different ways to do it. And we've changed a lot over 20 years from now, you know, from then to what we do now. We do a lot of things very, very different now.
Gotcha. And Howard, how are you, Howard?
Yeah.
So, two things. Someone asked a question: if you have severe myelomalacia, cord edema, severely myelopathic, they're afraid to do a laminoplasty because they're afraid that motion causes stretch-induced apoptosis of the spinal cord. Do you ever look in two situations: severe hyperintensity T1, T2 rated, and decide to do a fusion to maintain lack of stretch of the spinal cord? And some people believe in the setting of OPLL that's discontinuous, that a motion-sparing procedure may propagate or induce the OPLL to spread over time. Does that prevent you from doing a laminoplasty?
Yeah, that's a very good question. You know, for me, if you do a laminectomy fusion, that's the procedure that's going to take care of the spinal cord the best. And somebody asked about the K-line. K-line is actually that you draw the line from C2 to C7. And if the anterior that ossified, usually the OPLL, cross that line, it's not going anterior posterior. I mean, that's for the laminoplasty posterior and anterior in Japan. But if the K-line is positive, for me, I'm not doing laminoplasty. That's what, you know, Alan showed the case that you cannot, the laminoplasty, in my opinion, has a limitation. If you have a 90% mushroom OPLL, you cannot do laminoplasty, not because of the motion, but because of the amount of compression. So my point is that, yes, if you're worried about too much motion causing dynamic cord compression, if you're worried